All right. Well, good morning and welcome to day 4 of Technology Association of Oregon's Digital Health Week. I guess I can start my video. We are excited to continue the conversations focused on healthcare technology with today's program, Information Blocking Rule. Is your organization ready? I am not Skip Newberry. I am Riley O'Brien, Vice President of Events and Experiences. Skip is on a call right now with the governor, and so I'll be taking over just the programming of this one and the Zoom background. So if you have any questions, you can send me a note via the special events link. A couple of rules of engagement before we start. All participants have been muted. We ask you to remain on mute unless I, the TAO staff member, unmutes you and calls on you to talk. You may ask or respond to questions in the chat box publicly or privately by directing your message to me under the special events name. We'll be monitoring the chat box and respond throughout the discussion. We also ask that you engage via the participant icon on your screen. You can give us a thumbs up. You can tell us if we're going a little bit too fast for you. That would be great if you could participate in that way. We invite you to engage with us on social media during this call and throughout the day. We'd love to share what's happening at TAO and get participants takeaway from all of our events throughout the day and through the week. And we invite you to join us tomorrow at 11 a.m. or today at 11 a.m. to join us for a conversation on innovative health delivery and broadband network infrastructure. That will be taking place at 11 a.m. today. Oh, I apologize. That is the wrong dates on the screen. A huge thank you to Link Oregon, OCHIN OBI, HIMSS, Israeli Consulate General to the Pacific Northwest, and OCHIN for underwriting Digital Health Week. We appreciate their sponsorship and we're excited to explore topics related to digital health this entire week. And finally, it's my pleasure to introduce our moderator for this conversation, OCHIN's Executive Vice President of Government Relations and Public Affairs, Jennifer Stoll. Jennifer, you can take it away from here.
Thanks, Riley, and thank you all for spending your morning with us, at least a quick hour. We have a very exciting panel lined up for everyone today. And the conversation, again, I'm Jen Stoll, I lead government relations and public affairs for OCHIN. But the question on everyone's mind is information blocking is here. Are you ready? And so we're going to have a pretty good, robust conversation this morning about learning a little bit from the government perspective. We're going to learn from the DC perspective, and we're also going to have a chance to hear from on the ground. So with us today, we have Director John Graham. Director Graham is the Regional Director in the Office of the Secretary of HHS. He's based in Seattle. He is responsible for Region 10, which is Oregon, Washington, Alaska, and Idaho, right, John? Yeah, okay, good. And he's been serving in that role since April 1st of 2018. He comes to the role with over 2 decades of experience in the financial, economic, and policy analyst in the health sector. And he's worked at various nonprofit research institutes where he's led payment reform, regulation of drug and medical devices, health information technology, and in comparing in many international systems. So we're super fortunate to have John with us today. John's comments will be then followed by Senior Director of Government Relations, Jeff Coughlin. Jeff joins us from the HIMSS, and HIMSS is the Health Information and Management Systems Society. This program today is also being supported by our Oregon HIMSS chapter. So we're really happy to have Jeff with us. He's based out of Arlington, Virginia. He's the Senior Director of Government Relations at HIMSS. And in the position, he leads HIMSS efforts to build stronger relationships with federal agencies and facilities and facilitates the building of a nationwide network of advocates at the state-based initiative. So we're really, really lucky to have Jeff with us. And finally, my colleague and savant, Mr. Paul Matthews. He's our Chief Technology Officer and Chief Information Security Officer at OCHIN. And Paul's responsible for the technical delivery and hosting architecture for OCHIN's Epic and data analytics business lines. And we are very fortunate to have him at OCHIN, and he's been helping lead OCHIN's interoperability efforts to making sure that we are fully compliant with the new rule that's coming down the pike, or that is here, excuse me. It's been coming down the pike for 3 years, so and now it's here. So what we're going to do, the format of this event today is we are going to have about 8 to 10 minutes of introductory comments from each of the speakers. And then we're going to go into a robust Q&A. And I really want to encourage everyone to enter your questions into the chat. We want this to be interactive, and we really want to learn from each other today. So with that, I'd like to pass it over to Director Graham for opening comments. And Riley, if you could put up his slides, that'd be great.
Okay, thank you very much. And I'm just going to keep talking and assume that if people can't hear me, I'll get some kind of signal. So it sounds like you can all hear me. Well, thank you very much. And I'm going to hopefully give the least technical comments here. I'm the least technical person on the panel. And I've titled my little deck here, Historic Advances in Interoperability and Price Transparency at HHS. And hopefully I will explain to you why I bundled price transparency into my short comments, even though it's not quite within the cabin that was given to us. So it's an interesting time to speak to you all. I'm so glad I'm able to speak to you all. I'm not glad I'm not able to get down to Oregon, but I'm just up in Seattle, so that's close enough. And so I represent Secretary Alex Azar in our region, which includes Oregon, Washington, Idaho, and Alaska. So I'm not with ONC, but I'm tightly connected with ONC. They don't have any people in the region. And the other thing here that I think this is a very interesting topic to discuss. I've been discussing a lot of topics with a lot of people recently, and this is hopefully the most stable topic that we can address given the current situation. The current situation being what we call transition. So to be clear, we are legally in transition. There is a statute that puts us in transition, but to what are we transitioning? As you might have heard, Secretary Azar yesterday pointed out that the administrator of the GSA has not signed the documents to transition to another potential president coming in. So we will await that decision to be made. I am appointed by the current president. So if there's a transition to another president, I will leave office by or no later than January 20th. So I can only speak to what the current administration's priorities are and not to what a subsequent administration's priorities are. But I think when we look at what we're talking about here, a reasonable person would think much of what is baked in at this point will continue to be baked in. I remember when I was in the private sector, when Karen DeSalvo was the ONC coordinator and Farzad Mostashari, and the vision is not substantively different. The rule is now been sitting out there long enough that I'm sure everyone's well acquainted with the rule. And, we missed the statutory deadline in 21st Century Cures. But again, when I was in the private sector, I was somewhat involved in 21st Century Cures. And I remember back in the House Energy and Commerce Committee when Chairman Upton was the chairman and the Republicans had the majority, and Diane DeJette of Colorado was the ranking member. And they spent 2 years baking 21st Century Cures Act and putting all that stuff into it. And it was just a great legislative achievement of bipartisan consensus that we very seldom see. So, and I don't see any hostility to what is in that statute from either a future administration or the current administration. So there's a big difference there, of course, with the other big statute, the Affordable Care Act, which we had hoped to repeal and replace and did not do. So I think the future of the rule is, I would guess, stable, whatever the future is. So I think in that sense, this constituency that's on this call is in pretty good shape. Now, in terms of the problem we're trying to solve is, and again, I'd note 21st Century Cures, a little anecdote, just to kind of warm up the morning speech. When I came into the administration, a bunch of other Republican staffers came in from Congress. And there's, when the president signs a bill, he signs the red line version of the bill, so it looks kind of like an 18th century document. And copies of the red line guys had framed in their offices. They'd come in and join the administration and put up the red line bill. And of course, President Obama's signature is quite prominent, right? You can all recognize President Obama's signature. And this was the last bill he signed in December 2018, was 21st Century Cures. So all these Republican staffers were coming to join me. And they all had this bill signed by President Obama. I said, is that the Affordable Care Act? Get it off the wall. They said, no, it's the Cures Act. We all love the Cures Act. I said, great. So that's my little morning anecdote. So that was all good fun. Now I haven't lost track. It was just a cute story. And I didn't get a copy of that bill, but I would love to get a copy of President Obama's signed copy of the 21st Century Cures Act. So when we came in here, remember Seema Verma became the CMS administrator. And she had this horror story about her husband who had an illness. And she was in Indianapolis, and she was trying to get her husband in a good continuum of care between University of Indiana and other health systems in Indianapolis. And she was carrying CDs. This is within the last 6 or so years, carrying CDs around from one provider to another and burning CDs on her computer at home, and then, carrying them to new providers. And that was her pain point. And so she had a personal experience that when she and Dr. Rucker got their appointments in the administration, they really wanted to advance this. So we have a real strong commitment to this. Let's go to the next slide, please. And this is some interesting data that came from ONC. I thought that if you hadn't seen this, it came out a few weeks ago. I thought it was interesting. They compared 15 cities across the US. Unfortunately, Portland wasn't in there, but Seattle was in there. And just this dramatic difference in interoperability within cities, and also a progress from 2015 to 2018 in interoperability between, these are hospital-based systems. And I'm sorry, I know OCHIN, I'm very grateful to OCHIN for moderating and hosting us. I know that our OCHIN is more focused on the community clinics, but hope maybe ONC will do a similar study on community clinics later. The hospital study is quite interesting. It shows that, for example, Seattle, I guess, which is closest to you folks in Oregon, a really good level of interoperability, but not much improvement. Now, I guess there's nothing wrong with that. If you were ahead of the game in 2015 and you don't improve to the degree that, say, Philadelphia did or Washington, D.C. did over the last few years, that may be fine. But what's interesting about the trend line is it's not really a trend line. It does show that cities that were already highly advanced, such as Cleveland or Detroit or Miami, were already advanced in interoperability, would continue to increase much better than Seattle did. So I think that's quite a good finding. And it was really the first I'd seen looking at cities across the country. We spent a lot of time looking at the national situation in interoperability, but not so much regionally or in a city. So that may be a continuing focus, that let's look at cities that continue to need to improve, such as Atlanta, for example, or even I was surprised at Los Angeles. I would have thought with their health systems there that they would have been more advanced, or Washington, D.C., although it's improved. So I think more micro analysis we're at a level of maturity of examining these things that as we prioritize nationwide, we can say, look, this city, and of course, this is only 15 cities, so there's a lot more cities to go, and also the rural and suburban areas, that more micro targeting of where resources are needed, I think may be a direction things go. Next slide, please. I know I think we went, oh yeah, there we go. So of course, I know the subsequent speakers will speak a little more about the events of October 29th and kicking the can down the road on the dates. I know we'll be talking about that. Will they be kicked down the road further? I mean, I'm pretty confident this was totally COVID-19 driven. I don't think it was caused by kicking and screaming of providers saying we need more time, which I mean, that happened, but I don't think that alone would have kicked the can down the road. I'm pretty confident this is, as stated, a COVID-19 event. And so the progress of COVID-19 will, dictate what happens next. I'd like to finish my remarks by talking about price transparency, which again, maybe this audience isn't so focused on price transparency, but if we go to the next slide. So I've jumped to the strategic plan, that's okay. We sort of view this, kind of speaking for our administration, we view this as part of the same thing. we don't want interoperability on the data side just because interoperability is some kind of a good thing, is to empower the patient to be able to go from one provider to the other without the provider being able to build a silo up to prevent that patient from doing that travel. We want a liquid market, for lack of a better term. So price transparency is an important part of that. And how on your side, as provider IT folks, you build that in. That'll be interesting to observe in the years to come as the price transparency rules sort of sink their teeth in 2022, 2023. Now, if we do get to a new administration in 2021, their vision of price transparency may be different than ours. That's okay. Will they change that rule? I don't know. Certainly there's a faction that wants Medicare for all and no prices at all, but I don't think that's going to happen. So hopefully transparency, the teeth will sink in. And then finally, I'll just note, you probably all saw we did do the updated 5-year strategic plan. And those are the highlighted items, which are all good, common sense items, not significantly different than before. So again, I think the momentum is there. We're on track. And I think any change in administration should not cause too much disturbance into you folks rolling out your business plans and advancing in interoperability. Thank you.
Thank you, Director Graham. I know we're going to have lots of questions later, so really appreciate your opening remarks. And with that, now we're going to take a view from DC. And Jeff, thank you again for being here, and pass the baton to you. And Riley, if you could load up Jeff's slides, that would be great.
All right. Yeah, thank you, Jennifer. And I think my comments will build nicely on what Director Graham discussed. From the HIMSS perspective, the way we look at kind of the nationwide interoperability picture on the next slide really kind of focuses on 3 different pieces. And we talked a little bit about the regulation from the Centers for Medicare and Medicaid Services, and also the regulation from the Office of the National Coordinator. And kind of the third leg of the stool that we look at, and happy to talk about this a little more in depth, is the Trusted Exchange Framework and Common Agreement. So that's a voluntary framework that ONC has been working on that kind of provides another option for entities that are looking to facilitate broader exchange. I'm just going to kind of talk a little bit about what HIMSS thinks about the ONC and CMS regulations, but I think it's very much aligned with what Director Graham mentioned. So I think for the ONC and CMS rules, we are very much in favor of what each of the rules kind of put into place in terms of empowering patients and making sure that patients have more secure access to actionable information that assists them in directing their own healthcare and inhibits the blocking of information. And all of this contributes to more seamless care delivery. Director Graham talked about CMS Administrator Verma's kind of personal story. And I think that kind of led to the development of the My Healthy Data initiative at CMS. And I would say that everything that ONC and CMS have kind of done really builds on the My Healthy Data initiative and tries to kind of extend it to other areas. The other thing that I'll just point out really quickly about the ONC and CMS rules is I think that there is a piece that really tries to harness and capture opportunities for innovation. And folks on this call will know that other industries have gone forward and implemented and really included API technology, application programming interface technology. Healthcare has kind of done that in pockets, but I think what the ONC and CMS rules really signal is kind of a course for the broader healthcare paradigm to take full advantage of the promise of API technology. This kind of brings new innovation opportunities, and it also brings new market entrants that may have different ways of looking at how information should be shared, how it should be formatted, how it can be made available to the patients, again, which is kind of the ultimate goal of of everything that we're talking about. So on the next slide, I did just want to talk a little bit more about kind of the timeline related to the enforcement discretion that ONC and CMS have implemented related to interoperability rules. Folks will remember that these rules were actually finalized on March 9th of 2020. And that date sticks in my mind, just because the rule was released, but also because that was the date of, that was supposed to be the first date of the HIMSS 2020 Global Conference in Orlando, Florida. That did not happen in person this year, but ONC and CMS were going to try to use our conference as a platform to release their rules. But the rules were released, and the idea was that they would be formally published down the road after there had been a little time to work through kind of the intricacies of the Federal Register and the publication process. So the idea was shortly, obviously at about the same time as these rules were released, the pandemic really took full hold. I know on the West Coast and in Washington in particular, things were already kind of in full force by that time. But I think that early March was really when I think everyone came to the realization of what we were in store for in terms of COVID-19 and the spread of COVID-19. So ONC and CMS went back to the drawing board in terms of what sort of timelines they would include. So the idea was that in April they came out with some enforcement discretion, and what that included was you can see here on this slide related to what CMS finalized, and that's the admission, discharge, and transfer conditions of participation. So that would become effective May 3rd, 2021, and then the patient access application programming interface and the provider directory API would not really begin to be enforced until July 1st of 2021. On the next slide, just includes a little more information about how ONC looked at that, and they extended a couple of their deadlines. One deadline they didn't extend in April of 2020 was the November 2nd, 2020 deadline related to kind of the information blocking provisions. And so what happened was that that date remained in place. And as Director Graham just kind of alluded to, is at the end of October of this year, ONC finalized an extension in the compliance dates that pushes back many of the provisions till April 5th of 2021. I think what ONC and CMS have tried to do here is really establish a delicate balance in terms of what's required and what their expectations are for organizations. What they said back in April of this year when they made their initial announcement was, we encourage organizations that are kind of pushing forward with implementing these rules in the current time period to continue to do that, but the requirements are not really going to be imposed around organizations that may be a little under-resourced, or maybe obviously as the pandemic has spread across the country. I think it's happened in different waves, and different regions have been hit at different times. So I think the idea is to try to implement as much of these rules as they can in due time, but understanding that not everyone is going to be able to do that at the same time that they're trying to handle this global pandemic. So they are trying to strike a balance there. There is a lot of I think, anecdotal information about how beneficial these rules can be to dealing with the pandemic, and I think once we do get to the vaccine phase of where we're at right now, there will definitely be a lot of push to ensure that interoperability is in place, just because in terms of sharing information, and the vaccines that they're talking about have multiple doses. How exactly does our health system deal with that if there's not broader interoperability? So there's something to be said for working to implement the rules as much as an organization can in the current time frame. I want to just cover a couple other things on the next slide. The other piece that's really a part of this entire discussion has to do with the information blocking civil money penalties. So this is something in the ONC rule, there are several actors that are defined in terms of health IT developers, health information networks, health information exchanges. Those are the ones that are covered by the information blocking civil money penalties. And folks will remember what 21st Century Cures says, those information blockers, those entities that are deemed information blockers could be fined up to $1 million per violation. But it's just, it's important to note it's just those actors, health IT developers, health information networks, and health information exchanges. Providers have a different different sort of structure in terms of appropriate disincentives that they could be imposed for those folks that are deemed information blockers. But OIG is the Office of Inspector General within HHS. They've been working closely with ONC to develop this rule, kind of try to provide information on what they think the rules of the road are in terms of how the information blocking rules are going to be enforced. So the idea is that they really want to try to look at the intent of the folks that are deemed information blockers. And they don't really want to bring enforcement actions or actions that are innocent mistakes. So that's something important to kind of keep in mind as organizations move forward with implementing the rules. So on the next slide, I just include, we obviously have the ONC and CMS rules finalized. What we're waiting for is the final civil money penalty regulation from the Office of Inspector General that's really going to, as I mentioned, kind of define what the rules of the road are. That will be kind of enforced and in probably 60 days after the rule is issued. If the rule is issued, if the enforcement discretion that we're currently under is in play, that 60 days could make a big difference in terms of when things are enforced. I don't anticipate that anything will be enforced related to civil money penalties before that April 5th, 2021 deadline. And then the other piece that we're waiting for in terms of a regulation is a proposal around the appropriate disincentives for providers that are deemed information blockers. So the idea would be around possibly for the Centers for Medicare and Medicaid Services, for those entities that are information blockers could receive a payment adjustment, which could be considered an appropriate disincentive. So that's something that we will be anxiously awaiting the release of and trying to inform our membership and the broader community about what we think about that particular rule. And then I would say the other kind of pieces that are not really full regulations, but around trusted exchange framework and common agreement implementation. And that's a draft one of the common agreement, and then the qualified health information network technical framework. And I can talk more during Q&A about TEFCA if folks are interested and want to head in that direction. But I'll turn things back over to Jennifer now, and happy to be on the panel today and be part of this discussion.
Great, thank you, Jeff. That was really great level setting for everyone on what is arguably one of the more complex rules coming down, but also one of the most impactful rules to healthcare. With this, I'd like to pass it over to my colleague, Paul Matthews, for what OCHIN is doing to prepare for the information blocking rule in the 21st Century Cures Act.
Great. Well, thank you, Jennifer, and thank you to Jeff and John. Very informative. I'm especially interested in the slide deck from the OCHIN data brief and understanding more about that. So I wanted to do a quick overview of OCHIN because many of you may not know OCHIN. We're kind of the hidden gem in the Northwest, servicing and providing EHR hosted platforms to organizations across the country. OCHIN's mission is as a nonprofit organization innovation center. And so I've brought up the obligatory mission slide that we all like to use, and I'll keep moving us forward. OCHIN is spread out geographically across the organization as a membership-driven organization. There's about 123 separate organizations using our platform. These are provider and public health agencies, jail health services, mental health and behavioral health facilities, across the country that we host in a centralized Epic EHR platform, and they actually enter their patient records into that central platform. So when OCHIN looks at the 21st Century Cures Act, we look at it from the lens of both a provider. What does a provider need to do in their EHR to share information to the patient? We look at it from the Health Information Network, or HIE lens, which we are under the rule. And so we have to make certain that we share and meet the requirements of a HIN. And then in conversations with both our internal and external counsel and with others across the community, because we offer an EHR across to organizations that are provider organizations that are separate to OCHIN as a company, we also are a health information developer, a technology developer. And so we have to meet all three requirements. That was a little stunning for some people. And a lot of hospitals, I think, will that are providing extending their instances of their EHR out in the community are also struggling with the conversation that they're a HIT developer. And so I think that there's a great conversation to be had with HHS and ONC around, is that the intent of the rule to make people that offer a certified product but don't develop the certified product be part of the developer network. So as you can see, OCHIN offers this across a broad range of locations. We're servicing about 10,000 to 15,000 clinicians on the platform. At any one point in time, we have about 6 million patient lives that we are interacting with. And so it's a large effect on us across the regions. Our population is extremely diverse. And so when we look at this as well, is we're looking at patients that may not have access to technology. Our hope is that the new API ecosystem will assist in providing information to people on their smartphones to carry their records with them and to use those tools to be able to interact in their healthcare in a completely different way. Access to portals is not always available to these people. They often have access to a mobile phone. And so web-based portals don't work because they're often too small. And so the use of new mobile applications integrating into those APIs is something that we look forward to and have been seeing a small uptick over the last few years since our API systems have been online since early 2017. So when we look at the Compliance Act, it's very important to understand what is being shared. Right? We've talked about the policy side of the house and the governmental regulation side of the house. But from a patient standpoint and provider standpoint, what is being shared to the patient? Because while all of this is stuff that the provider has to do to be in, to meet the requirements of the law, the patient themselves is being affected by the sharing. And a great, for instance, on this is that a patient is going to start seeing a lot more information within their patient portal and on their patient mobile applications. And they may see information that they've never seen before and earlier than they've seen before without consultation from their provider. So there's going to be an entire education requirement to the provider community of even to the point of things like, how do you write your provider notes? How do your nurses write their notes in the EHR? And so we've produced education materials for our communities where we share education and language changes to the providers of what you should, how you should state something in the note versus saying a patient is non-compliant or refuses to take their medications, that you may want to write that in a different way so it is not changing the relationship with the provider because of the way the note was written. Additionally, it's important for the notes for the nurses and the providers. There has been a long history within the notes of actually including personal cell phone numbers or contact information, telephone numbers within provider notes or within nursing notes. A lot of times you don't want to share that information because you will start receiving direct phone calls, or could, from the patient directly to your personal cell phone numbers. Nurses may have included their signature block in their notes. And so these are just things you need to think through working through the release of notes that you may want to change in the way that your practice actually works within the EHR. The other place that we see changes is around laboratory result release. A lot of providers have angst about releasing the laboratory results immediately to the patient. And we've had these same conversations internally. What if a laboratory result says a patient has Huntington's disease? What if you release a result that says the patient has HIV? The law is pretty clear. You shall release the information to the patient immediately. So where the provider education comes in and the patient education comes in is preparing materials to share with your patient that says, when this is implemented by our provider organization, you will start to see information that the provider may not have already seen. And that you need to give the provider a couple of days in which to reach out to you and provide you a consult on the meaning of those laboratory results. So that the patient is going to see this information and is, of course, going to call immediately to the provider if they have a negative result. And you need to be prepared to have probably an increase in calls in a short time during the implementation phase until everybody adjusts. So one of the things that we've been pushing out to our provider community is education materials for patients so that they can share a one-page document or a short flyer with the patient about the changes that are coming. So when the patient logs into their portal on the day that it is implemented by the clinic, they know that they're going to see this new information, what it means, and what they should do to communicate with their care team as far as these new results and notes are showing up. It's a lot of information. We also want to take a look at what's really in the law. This doesn't remove HIPAA. One of the things that we've been asked a lot about is, well, if I'm having to share now all this additional information, what about HIPAA? HIPAA still governs. So it's not changing the rule under HIPAA. And HIPAA allows this information to be shared with the patient. It has been predominantly a long-term battle of providers' angst about sharing the information with the patient has often reduced the amount of sharing, and the technology not there to allow the sharing to occur, even if they wish to. And so HIPAA still governs, state and local regulation and other federal law still governs. However, you have to now look at how you will put exceptions if you want to withhold information and document that in the chart. So at OCHIN and many other organizations across the country, the way that's being done is that we're removing all barriers at departmental or default settings that will not share information by default. A great instance is notes. A lot of organizations were not sharing to their patients the provider and nursing notes. We have taken that responsibility and said, great, we're going to remove those default settings. All notes as of this date will be shared to the patient. And then the provider on a note by note or encounter by encounter basis is going to have to include a documented exception to why they didn't share something. So I'll sort of talk that through. We're going to share everything by default, and we're going to share it immediately to the patient by default. However, a provider can choose to uncheck a box not to share a specific note with the patient, and then they will be prompted to choose one of the 8 exceptions and document that exception with enough detail in which to be able to say, this is the exception I've chosen and why I'm not sharing this immediately. And that has to be done at the provider level. This is not an easy conversation with the provider community or the clinic's leadership to go through and say, we're changing your practice and putting an additional requirement on your provider staff to choose why they are not sharing and document the legal exception that they're choosing. And so we've tried to make it as very simple and as very easy to execute as possible, but we need this to be able to go back if there is a withholding or a future monetary penalty that comes forward to say, this is the exception that was chosen, the reason the exception was chosen. Additional to that, we're going to be providing our communities with additional reporting functionality. Reporting will include things like, as a provider organization, how many times my Pareto of exceptions have been implemented? Am I choosing one exception more frequently than another? Am I incorrectly choosing a licensing exception? So I can actually have interactions with the organization and demonstrate why they've asked them questions about why they're choosing these exceptions over the correct exception, or just allowing the data to flow. And secondarily, having the medical leadership within a clinic have conversations with their individual providers. So providing reports that says provider X in your department has chosen to exclude the sharing of information at this frequency comparative to all other providers in your department. And why is that exception being chosen? Is it they have a different panel of patients, or is it that they are still looking at this under the lens of, I don't want to have the patient be misunderstanding the communication or causing angst or anxiety to the patient if I release that note. So that should not occur. We should be releasing the note. We should not be worrying about the anxiety. We should be releasing the information, then having the discussion. So with that, Jen, I think I will pass it back to you for questions. As you can see, where the rubber hits the road side of the house, and have been pushing this out. Just let everybody know, we are going to be pushing this out to our community on March 19th. We were ready to roll it out for the November deadline. But given the additional time, it is really about how we're educating down to the individual provider level. And we're just taking that additional time in our communities to push that out.
Thank you, Paul, and I appreciate some of the challenges that, the real life challenges that we're going to face with this rule. So what I heard though, from Paul, your presentation, is impact on privacy and potentially HIPAA. And we know that there is a potential rule in the works around HIPAA, and I'd like to throw it out to the group. Maybe Director Graham, if we can start with you. Where do you see HIPAA going? The larger conversation is, we have a lot of states too that are looking at strengthening privacy laws. Do you think this is going to impact that? Just what do you think is going to happen to privacy in the coming years? And Director Graham, if we can start with you, and then Jeff, if we can go to you.
I'll be quick and whiffy. Privacy will continue to be important. As you pointed out, they're considering a rule, and since I'm an employee of the administration, I can't really comment on that. So thank you.
Yeah, this is Jeff. I can weigh in and just say I think Paul kind of touched on things very, very nicely. We are waiting for this HIPAA proposed rule to come out. I think one of the dynamics that we're looking at is, with this rule kind of coming out at the tail end of the Trump administration, what does that look like if we do, when we on January 20th, when we move to a Biden administration? So I think that's something that that we'll be looking at very closely. But it has been several years, shall we say, since the kind of HIPAA statute has been updated. So I think that that's a piece of it. But I do think that some of the things that we were talking about related to API technology and related to kind of more patient control over their information, that kind of speaks to a broader, privacy, protocol and kind of infrastructure that's something that Congress would have to weigh in on. And I know several folks in Congress are very interested in that. But I do think that it's something that's going to be high on the agenda for a lot of folks. It probably would be helpful to kind of get this taken care of before a pandemic hit. But I do think that folks will have to, especially in the provider community and probably in the halls of Congress, will have to be focused on addressing the pandemic for the next several months. So this could be something that is kind of dealt with more broadly in terms of just privacy and how it impacts health data privacy, down the road, maybe later in the spring or maybe next summer. But I do think it will be impactful to kind of make sure that we have information that is accessible to folks across different platforms, and I think the biggest thing is that the patient remains at the center of care. The patient understands what they're doing when they share information, and that the provider has the kind of resources, as Paul was talking about, kind of support them in their broader efforts to help help take more control over their care.
Paul, do you have any thoughts on impacts to privacy?
Not from, I mean, the biggest concern that I think we've heard from our provider communities are the patient authorizing exchange to a non-covered organization, a non-covered entity. So because the patient will make the choice, which they rightly have, to release their data to, say, a third-party organization that builds a tool for access to their medical records, that accidental release or re-release of that information is going to constitute a immediate call to the provider, because the patient may not understand that the release was done by them. So they may release it to company A, and company A may then re-release that information or accidentally release that information into the wild, but the patient only knows the relationship to the provider when it comes to the use of that information. So that is a concern our providers have. Will they see an increase in calls either from patients or even calls from attorneys that are going to use this as a way to wield a stick, either correctly or incorrectly, for a number of years, because it's brand new and nobody knows it. So that's, I think, the biggest one we look for, Jen, is that. The other one on the regulatory side is I'm really hoping that the sharing of information at the patient level may actually get past the angst at the governmental level of sharing information when it comes to public health. You know, we're suffering right now in a pandemic where public health regulation is not necessarily as clear as it could be. And I would love to see changes across the board in public health sharing of data around this, because if I can't send information to an organization because a misinterpretation of the regulation is there, it becomes difficult to really cancel out the effects of this pandemic.
Yeah, and to that point, I'm monitoring the chat, and one of the questions that came up is how do we normalize the various data elements and free form notes submitted to platforms? I don't know if you know, there's going to be a lot of conversation around standards. If anybody wants to take a shot at that question or have some thoughts around it.
I'm just looking through the questions.
And maybe we can talk about USCDI, Jeff, and if you wanted to add any thoughts about USCDI and what that may mean to healthcare providers.
Yeah, I think, yeah, I'm happy to start, Paul. But you know, but I think Paul talked a little bit about USCDI, and I think the important thing to note is that USCDI is serving as the definition of electronic health information, of the information that needs to be available and accessible for exchange, really through for the next 2 years, through 2022, when the requirements around what the definition of electronic health information that needs to be shared underneath the ONC rule in particular is going to be required. So USCDI is those data elements. It's something that ONC is going to be updating on an annual basis. They just had a call for new data elements to be submitted, and they'll be putting out a proposal very soon. Well, they'll look at and see if there are other additional data elements that need to be included. You know, from the HIMSS perspective, one of the things that we talked about submitting was data related to kind of the social determinants of health, and food insecurity and transportation insecurity, and housing insecurity are all things that I think need to be available and accessible in the near future to make sure that providers have a clearer picture of their patient situation. So that's the kind of thing that I think we would love to lean on OCHIN, since given your work with health centers, et cetera, on a lot of those areas, I think there's a lot of overlap.
Yeah, Jeff, to talk to that, I mean, we have taken things like SDOH information and incorporated that into the workflows of our providers out in their communities. I think we're running in around 500,000 patients have been screened for SDOH information, which is probably one of the largest single repositories of SDOH in the country now. When we sort of think about data elements that are being shared through here, one of the efforts that has to be done by a provider organization is looking at their things like laboratory results and other information, and make certain that if they've created their own note types, that they have mapped those notes over to one of the standards for release. Because while the EHR vendor may be automatically releasing certain note types within the US CDI construct, they may have notes that they've created themselves, or note types they've created themselves within the EHR that need to have mapping to one of those constructs so they can release that information. The same with lab results. If you're using internal laboratory testing results, how are you releasing that information? How does it map back to a standard that can be shared with the correct codification, RX norm codes on meds, LOINC codes on laboratory results, so that information is being shared appropriately. And that's an ongoing work that will need to continue.
Great. I'm going to take one more question that came from the chat, and it's around health information exchange overall, and potentially different methods in which to exchange data via the national frameworks, such as Care Quality, Commonwealth, or eHealth Exchange, or the local regional health exchanges, the RIOs. Anybody want to take a shot on what this could mean for the different ways to exchange data, and maybe how TEFCA plays into that?
So I'm happy to take a first stab at that. So one of the things I look at is I have a huge amount of exchange going on today outside of the API work for the patient. So if I'll separate those two: APIs to the patient-facing side of the house, and then provider to provider or provider to other organization exchange. We've over the years we've been integrated. I think I have 23 separate regional HIOs that I'm connected to. Of those 27 regional, or those regional HIOs, they have varying levels of degree of exchange capability. I'm also connected to Care Quality. We're connected to the eHealth Exchange Hub. We push information to third-party provider groups through discrete or custom one-off interfaces to them. So I have a lot of exchange. 40+ million records for patients are exchanged every year for OCHIN at a clinical summary level. That's not including discrete data. So as I think about the changes that this is bringing, it's adding additional information to be released in a better way, and it is clearer when it arrives at the receiving organization what data they've received, what coding standard they've received, and it's removing ambiguity in the exchange of data. When I look at the patient exchange side of the house, I'm excited. About 3 years ago, I gave a presentation in Alaska to a research group. And in that research conversation, I said researchers and third parties, and especially payers, should be looking to the patient to release them the additional information through their API, because they could reach out to the patient. The patient could choose then to authorize access to their medical record through these APIs, and they would be able to participate in research by releasing their information to that organization. Now that's going to be have to be done on IRB approval. There's a whole process that they'll need to go through, but this is going to open up a whole new way of looking at information, including third parties. With my ex-wife, we had a huge medication list. In that medication list, we kept on going back, going, well, why am I taking this med if it's clashing with this one? Why is this one causing this outcome? And am I just taking these medications because I have another, this other med has caused an issue for me? And so having an application solution that could actually pull in that entire medication list and actually evaluate it against the condition, and actually have a third-party app look through that with AI capability, to sort of bring forward a conversation with the provider for that patient would be wonderful. And I'm hoping that we'll see this explosive growth in applications that provide better care and understanding to the patient of their condition in a secure and compliant way.
Thanks, Bob. Jeff, any final thoughts on this issue, or Director Graham?
Yeah, I think Paul summed up everything very nicely. The only thing I would add, I think that 21st Century Cures did include this provision related to the creation of a voluntary framework. The Trump administration has done a great job kind of taking that language and trying to build the trusted exchange framework. And there have been drafts that have circulated. There's still kind of more kind of regulatory-like work that needs to be done, but I do think that it's kind of putting us heading in the right direction in terms of providing options for facilitating broader nationwide exchange. Some of the things that Paul mentioned, some entities do not have a vendor-based exchange option. Some entities do not have the ability to connect to a regional or a state health information network. So the idea then would be to kind of turn to a trusted exchange framework and common agreement that would provide nationwide access. So I think that again, the work that the Trump administration has done on this is definitely putting us heading us in the right direction in terms of, I think, where we need to be in terms of options that are available to everyone participating in exchange.
Okay. Well, with the remaining minute, I'd love to give you guys each a couple of seconds to kind of wrap up your thoughts and any parting comments that you wanted to present. And Director Graham, can I start with you?
Yeah, I'm going to go off the reservation. I was really, it stuck what Jeff said about actually amending the statute. And I'm not recommending or advising, and this is not administration policy, but HIPAA was 1996. I mean, good heavens. And I think the privacy rule, when was that? 02 or something, right? So, you all live in an environment of rulemaking with legacy statutes that, what are you talking about here? And the rest of the IT communities like that as well. I think of Section 230 of the Communication Decency Act, or when they were regulating net neutrality, it was built on the 1930s Telecoms Act or whatever. But I know, Jennifer, you come from the prescription drug business, and I was in the medical device business. Those statutes get reauthorized every 5 years. And if they didn't, the FDA would go to business, right? Because it's user fee funded. So there's a whole different environment which you could seek to create if you wanted to, where you engage Congress continuously and you get what you need through more engagement on statutory reform rather than just relying on rulemaking. But anyway, that was way off the reservation. Thank you.
Thanks, Director. Jeff, any thoughts? Final thoughts?
Yeah, I would just say that I'm very heartened by Paul's remarks related to kind of rolling out implementation and compliance with the interoperability rules, and the fact that you all were ready to go for that kind of November 2nd compliance date, but are kind of planning on that March 2021 date. Really, I think speaks to the great work that you've done. So I would encourage other entities to try to kind of equal that and push forward as quickly as possible, because I do think broader interoperability is going to be helpful in better addressing the pandemic. And the sooner we can get these rules in place, the better, understanding that not all organizations are going to be able to get there until the requirements are actually fully enforced.
Great. Paul, 5 seconds is about what we got.
I really appreciate everybody on the conference call today, and I'll leave it at that, Jen.
Great, thank you. And we heard 3 very unique perspectives today on the 21st Century Cures Act. Thank you all for participating. Riley, I'll hand it back to you.
Thank you, Paul, Jeff, John, and Jen for pulling this all together for us. It's a great way to end our week. We have one more program coming up at 11 a.m., Innovative Healthcare Delivery and Broadband Network Infrastructure. We hope you all will join us. You'll be able to find this recording on our YouTube channel this afternoon, as well as on our blog with a look back at today's sessions. Thank you all again for joining us, and we hope you have a wonderful Thursday.
Thank you, everyone.
Thank you.